So while you guys are waiting, one of the things that I'd like to mention is that we will have an open Q&A on this medical webinar. Now, the medical webinar lasts about 45 minutes to maybe 50 minutes, right around there. But with the open Q&A, it could take a little bit longer, but we absolutely love your questions. We want to hear your questions. Also, you'll want to stick around to the end because I will let you know how you can receive your CE credit, as well as help you to understand a little bit more about HealthyStart and some of the education courses that we have available. So on top of that, I would like to introduce you to our presenter for this evening. I'd like to tell you a little bit about Leslie Stevens. Leslie has actually been involved in the world of pediatric sleep, breathing, and airway health for over 35 years. As CEO and president of HealthyStart, Leslie is also an international lecturer and trainer. I really don't think there is a question in the reference to the subject of pediatric sleep, breathing, and airway health and HealthyStart's connection that she cannot answer. And really, when you have the backing of a company like HealthyStart or Orthotane, you have over 52 years, you have over 4 million cases, and tons of research to back you. Now, most importantly, Leslie is the mother of 3, so her goal and desire is to provide every advantage for children to allow them to live healthy and happy lives. One of the things that you're going to learn tonight is that there is a silent epidemic affecting 9 out of 10 children, and this epidemic manifests itself in a variety of symptoms that can be easily overlooked, misdiagnosed, and most unfortunately left untreated. It's really critical that children are evaluated for sleep and breathing habits. Leslie's mission is to educate both dental professionals as well as parents to ensure children a lifetime of health, happiness, and success. So I would actually like to take this time to hand the floor and the mic over to Leslie Stevens.
Thank you so much, Susie. I am absolutely thrilled to be here tonight, and looking forward to kind of giving you an opportunity to learn a little bit more about what we do. Susie, maybe you can allow me to share my screen. Thank you. So tonight, I'm not sure how many of you have had the opportunity to learn a little bit about sleep already, and maybe have the opportunity tonight to learn a little bit more, or maybe learn something that you might not have known already in regard to sleep. I always like to present this because it does give you kind of the aha moment that maybe you haven't put all the dots together. So I'm always interested in the questions afterwards, your comments, anything you can add to the conversation is always great. So I'm not sure why this isn't, okay, we're gonna do it manually tonight, I guess, for whatever reason. So anyways, a little bit about some of the background. About a year and a half ago, no, almost 2 years ago, the ADA actually accepted policy that basically makes it a requirement for each dentist to observe and identify sleep and breathing issues in patients, but also look at deficiency in growth and development. So it is really imperative that you understand what this is about, how this basically can be done in a dental office, and most importantly, understanding the dynamics and the numbers of children that are going to be demonstrating these issues. So when we talk about issues, we have outward symptoms. And what makes this such an interesting conversation is that not only you as a dental provider can identify these outward symptoms, but parents can as well. So having this conversation is not just for your benefit of understanding what you're looking for, but you're going to become an educator to both your patients as well as the parents of your patients. Because this topic does not necessarily affect just a few kids. It actually affects 9 out of 10 children will suffer from one or more of these outward symptoms. So that number basically demonstrates about 40 million children just within the United States. I travel all over the world. I was just in Albania. I've been to Cambodia, Thailand, Japan, all of these areas. It really does not matter where we are in the world. These conditions exist, and this kind of epidemic numbers exist even in the most remote countries. So it is extremely critical that we learn about it, we know how to identify it, and maybe even more importantly, we know how to educate our community about these outward symptoms. So taking a look at what these outward symptoms consist of, they include mouth breathing, snoring, teeth grinding, swollen adenoids and tonsils, chronic allergies, eczema, asthma, ADD, ADHD, aggressive behavior, depression, irritability, anger, pair problems, few friends, bedwetting, difficulty in school, especially in the subjects of math, science, and spelling. And I'll explain a little bit the reason why that is, and it has to do with the areas of the brain that those skills basically originate from. We also see delayed or stunted growth, restless sleep, nightmares, morning headaches, daytime drowsiness, frequently waking up at night, sleep talking and walking. And these are probably the most prevalent. There is a whole array of other outward symptoms that also go along with it, but identifying the most prevalent ones will help you in that conversation with a parent, but also looking at the underlying root causes, which we will go into. So what we're talking about tonight is really a silent crisis among America's children, but also a global epidemic. So when we talk to parents about these outward symptoms, many parents will identify or will say, yes, my child has this, and we go to a specialist to address this outward symptom. Or, yes, my child does have an issue with ADD and ADHD, and we see a separate specialist to address that symptom. And unfortunately, all these outward symptoms become a different specialist for each one of them. And typically what these specialists recommend in order to address these outward symptoms can include stimulant drugs, prescription drugs, psychiatric testing, counseling, therapy, surgery, sleep studies, allergy testing. The list goes on and on. But what parents need to understand is that many times these outward symptoms can be linked together, and they can look for an underlying root causes. So if we look at society today and how typically these outward symptoms are addressed, it's usually addressed as symptoms only. They do not look at the root cause. The medication or the prescription tend to be short-term Band-Aids. And many times they involve several drugs with many side effects. And unfortunately, these drugs can be costly, painful, time-consuming, and ineffective. So what are the root causes of these outward symptoms? Well, research over the past 20 years has linked each of these outward symptoms to root causes such as mouth breathing, lack of nasal breathing, narrow palate, improper tongue placement, and jaw relationships. So understanding kind of that brief overview, how do you as a dental professional screen for sleep? And we're very fortunate because we have kind of a tier system that can help you identify. So the very first way to identify and maybe get an inkling of what's going on is just visual. You can pick up different clues within a child that would give you suspect to investigate further. So for instance, take the two children that are on the screen. The girl on the left, right off the bat, you see the dark circles, or we call it venous pooling under the eyes. But notice how her head is also lurched forward. And this head being lurched forward is an indication that typically the child is trying to expand their airway. We tend to see that kind of position of the head in children that are struggling. The boy on the right, also look at those deep circles under their eyes. But take a look at the posture of the mouth and the lips. The lips are separated. Look at the rolled lip, usually an indication of something maybe of an overjet, but it's basically impacting the placement of the upper arch to the lower arch. It also is typically maybe an indication of mouth breathing. We also look at how that lower third of the face kind of lines up. This particular child looks like he almost has a double chin, when actually he doesn't. He's not a heavy child, but the chin, the neck is all blended, so it tends to look more thick. Or the lower jaw is retrognathic, so it tends to look like there is the opportunity for a double chin. Let's take a look at the profiles of the children. We want to see almost a straight line from the forehead down through the lower third of the face. And as you can see, the deficiency in that lower third, that mandible is really retrognathic. Take a look at how that lip rolls over, again, interfering the position of the upper and lower arch. Usually can cause that retrognathic, being that it's not allowing that lower chin to develop forward. We also see that the lips are separated. Tendency is a mouth breather. Take a look at the girl on the right. Again, making that line down the front profile of that child. You can see the deficiency of the lower third. Again, a rolled lip. Look at how the lips are parted. Look at the circles under their eyes. But also look at how that lower chin basically blends right into the neck. There is no definition there. Again, retrognathic tendencies for that mandible and the lack of growth in that mandible. So these are all indications. Now, the HealthyStart has created a unique sleep questionnaire. And the reason why, it gives you 27 of the most prevalent outward symptoms of sleep. It also allows the parent to identify the degree of severity of these conditions by having the parent designate a numerical value from 0 to 5, 5 being the most pronounced. So the initial, or the first column, is the initial prior to treatment, where the parent would indicate. Now, we have research studies, and we'll show what that means and how we look at each one of these numbers. Number 27 talks about speech problems, and it's extremely interesting conversation. And as we progress into our digital series, we'll go more into the speech element. But the overall is very interesting. 67% of the consonant sounds that we initiate and develop, even as a very young child, starting at age 2, basically either that sound begins in either the palate of the mouth or lip seal. And as we talk tonight, you're going to realize that with mouth breathing or consistent use of pacifiers and bottles, that tongue is laying low. It doesn't get in the palate. Many times we see a vaulted palate. What that means is the tongue can't make it into the palate. And we see a variety of different sleep issues that occur, but also speech issues go hand in hand. I took a very random survey of different speech therapists, and I asked them how many of the children that they see for speech issues also had ADD and ADHD. And they laughed at me and they said about 100%. Now, I'm not saying it's 100%, but you can kind of see where a lot of these issues all overlap. And we start seeing a pattern of different situations, different patterns of behavior, certain deficiencies that go hand in hand with each other. And this sleep questionnaire is a great tool that not only informs you of what's going on, but it also helps to educate a parent to understand that, maybe snoring and bedwetting have something combined. Maybe there's some relationship. And it prompts them to ask you that question, and it gives you the opportunity to educate your parent. So these are all important aspects of this sleep questionnaire. Now, a study was done on over 500 children using this sleep questionnaire. And what was discovered through this research? So the results were that mouth breathing and snoring are commonly associated with more sleep disorder breathing symptoms than any other symptoms studied. 9 out of 10 children had one or more outward symptoms of sleep disorder breathing. 60% of the sample had 4 or more outward symptoms. 1 out of 5 children experienced bedwetting at a later age. And that was a shocker for me, just from the standpoint, I didn't realize how prevalent bedwetting was at a later age. So if we look at, say, a 6th grade class, we can experience a classroom that has 20 children that at least 4 of them are chronic bedwetters. Now, we don't talk about that very often, but it is really kind of eye-opening to understand how many children experience this, how detrimental it is for the child, and obviously for the parents as well. So it's something to be aware of, because unfortunately, even in a sleep questionnaire, a parent might avoid that question. So we can talk about how we present it so that you'll have a more accurate view of that patient sitting in front of you. And this last point is critical. Between the ages of 4 and 12, 92.6% of outward symptoms do not self-correct, while 30% worsen with age. That is a horrific statistic, meaning that if a parent comes into your office and it is identified that they do have these outward symptoms, and we look at the underlying root cause, we realize that that child has less than an 8% chance to self-correct. Now, I'm not a gambler in Las Vegas, but I know those are pretty poor percentages. And if I'm looking at the well-being and the health of my child, I'm going to give them every benefit I can give them. So if I'm only going to have an 8% chance of self-correcting this symptom, I'm probably going to be more apt to address it early and to address it as soon as it appears. So that's a really important percentage to have in your back pocket when you talk to these parents. We talked about mouth breathing. Mouth breathing was actually the most highly recognized outward symptom. 43% of this study exhibited mouth breathing. The reason why mouth breathing is so detrimental is because just by the mere ability or the mere condition of opening a mouth by a half an inch basically will reduce the airway by 6 millimeters. So if you have a child who is 7 years old, typically their airway is only 7 millimeters. So if that child is mouth breathing, that child is trying to breathe through 1 millimeter of airway space. Well, while a child is sleeping, that important portion of sleep called REM sleep is not going to be obtained if they are trying to breathe through 1 millimeter of airway space. REM sleep requires more oxygen. If there is not the proper or the amount of oxygen necessary to get into REM sleep, that child is not going to have the reparative sleep that they need. So that's kind of where this is heading. We also realize how important nasal breathing is, because nasal breathing will be the right combination of oxygen and additional features into the body. So take a look at the different percentages that occur within a child's sleep and these outward symptoms that we see as being prevalent. We also know that if a child is mouth breathing, we will see 8 other outward symptoms. And these other symptoms, the most highly correlated were snoring, difficulty listening, often interrupting, talks while sleeping, allergic symptoms, fidgets with hands, restless sleep, teeth grinding, feels sleepy or irritable during the day. So the implications of this study is the findings show that sleep disorder breathing is much more common and affects children even as young as 2 years of age. There has also been an additional study that actually shows that these sleep issues can actually start to start to develop even before a child is born. We see children that are already sucking their thumb while they're in the womb. So we see a lot of these issues even as young as in the womb. We also begin treatment as early as possible to ensure permanent changes. We identify outward symptoms displayed in 90% of the children that enter your practice that can significantly reduce this epidemic and enable you to successfully treat the overall health of your patients. So let's talk about airway and addressing the habitual issues. As we talked about, we want to create a large airway in order to accommodate the development of the oral cavity, but also provide basically the vehicle for the oxygen to enter the body. So many times we talk about what is a normal airway. Well, sometimes an easy way for a visual is to take the size of the tip of the child's little finger. That should be equivalent to basically what the airway is. If we have something that's compromised, say mouth breathing, eliminating that airway down to 1 millimeter, it's almost like creating a coffee stir effect instead of creating a garden hose effect that allows a proper amount of oxygen and the proper development of the airway. If you want another visual, which is very helpful, is look at on the right-hand side is the ideal airway for a 7-year-old, which is 7 millimeters. That circle basically illustrates 7 millimeter diameter airway, and that is the equivalent to 100% airflow. Now, if a patient is mouth breathing, that airway will be reduced by 6 millimeters down to 1 millimeter of airway. So look to the far left, it's almost the size of the top of a pinhead, extremely small, and that represents 11% airflow. So if a parent can see that, they understand how critical it is in order to maintain the diameter of an airway in order to gain the proper and the ideal amount of oxygen for that child. Why is this happening? Why are we seeing more and more children presenting with these sleep issues, breathing issues, airway issues, deficiency in growth and development? Well, a lot has to do with the prolonged use of pacifiers as well as nipple bottles. And the reason being is, for instance, the nipple portion that is in both a pacifier and a nipple bottle depresses the tongue. So as we said before, the proper place for the tongue to be at rest is up in the palate. So if you said the letter N, where that sound ends is where that tongue should be at rest. Try doing it right now and see where your tongue is during rest. Majority of adults will say, uh-oh, we have another problem. Also, with the tongue laying low, the tendency is for the mouth to open. If the mouth is open, guess what? We're going to be breathing through our mouth. Now, when I had indicated to you, if you put that tongue in the palate of the mouth, in the position where the letter N, that sound ends, there's only one way you can breathe, and that's through your nose. That's why creating the environment in order to breathe properly, we need to create the function and the proper placement of both the tongue, the lips, and the growth and development of the oral cavity. Another contributing factor is the lack of breastfeeding. As we know in the world, typically both mother and father work. And with that comes obviously the lack of ability to breastfeed. I always say, caution yourself when you bring this up, because every mother will have a tendency to blame herself. I knew it was my fault. I knew this was going to happen. I'm responsible. So really, we can't go backwards. We can only go forwards. I say it doesn't really matter at that point. But now what we're going to do is create the proper swallow and create the proper environment for the oral cavity so that your child can strive. Another area is soft diet. obviously with the lack of a hard diet, we're not able to basically expand and develop the oral cavity. With the soft diet, the tendency is a collapse of the arches. This also happens with the use of pacifier and nipple bottles because there's a suction that's created that basically collapses the arches. So we see more crowding. Obviously, if there's too narrow of an upper palate, the tongue will never be able to be in the right position where it needs to be. So all of these are contributing factors of what we're seeing in today's society and the numbers we're seeing. What do we also see more of an orthodontic or maybe a posture of the oral cavity is if you see a patient, look at see if there's an open bite, see if there's a tongue thrust. Obviously, we talked about the lips not being sealed. These can also be a result of the pacifier, prolonged nipple and bottle use, as well as finger and thumb sucking as well. So when we look at the airway, we're going to look at the nasal cavity, we're going to look at the hard palate and the soft palate, we're going to look at the position of the tongue, we're going to look at the pharynx, the oral and the nasal pharynx, and we're going to look at the airway. So these are kind of dynamics that maybe would be helpful to show to a parent so they understand where and what we're looking for. We had talked about mouth breathing, and then we had talked about eliminating the mouth breathing but creating the nasal breathing. And so often we don't discuss the importance of what the nose function is in the body. And the nose basically has 5 functions. It serves as an air passageway. It warms and moistens inhaled air. Its membrane traps dust, bacteria, and other foreign matter. It contains receptors that sort out odors, and it aids in pronunciation and the quality of voice. How many times have we seen children sitting in their car seat, mouth open, sound asleep? Obviously, children shouldn't get worn out too easily. And these are indications that maybe they're not getting the proper sleep that they should. Maybe they're not getting the REM sleep. When they open their mouth, they're closing the airway, so it becomes interrupted sleep. So as we had shown in that last research study, we see 43% of that study of children mouth breathing. I want to play this little video. This is extremely powerful. Many doctors use this when they talk to their parents because it demonstrates what this interrupted breathing looks like. It shows the struggle that occurs, but more importantly, it will demonstrate what can be done and how it can be eliminated. And this is going to be very important as we progress in our conversation tonight. So take a listen to Eli.
Now he's holding it. That was holding it. He's still holding it. He's trying to take in air. There he goes. Now watch. He's holding it. He's holding it. He's holding it. He's holding it. He's still holding his breath, and he's going to gulp again. There he goes. That was it again. And he's holding. He's holding. There he goes. This has been 3 minutes and 15 seconds. You can see how many episodes he's had of not getting calm breaths in. Now, watch what happens when I take his jaw. I can bring it forward. If I can. Let's see if I can. And I open his airway. Just bring his airway forward. There we go. Now he's breathing through his nose. his airway. I'm opening his airway, just pulling his jaw forward ever so slightly. And now he's breathing through his nose quietly. His mouth is a little bit open, but he's breathing through his nose. This way. Air quietly breathing, you don't hear him anymore. And all I did is gently bring his jaw forward.
So obviously this is tremendously powerful. Every time I listen to this, and I watch it frequently, the power is amazing of what we can do if we could just be able to create the proper environment in the oral cavity. And there are different features that we need to look at. So let's take a look at the first, and that's airway. What is airway? What's normal? What's not normal? So taking a look at this cephalometric x-ray, you can see on the left-hand side, you have a constricted airway. Now, there'll always be critics who'll say, oh, a cephalometric is two-dimensional, it's vertical, it's not the whoops. Are we still on?
Leslie, it looks like your screen, just need to share your screen again.
Okay, I'm just going to, let me try sharing and it'll come back up. Do you think? Let's try. Okay, can you hear me?
Yep, we sure can.
Okay, so sorry guys, I'm not sure what happened. It's that mysterious being that always takes over our internet or our PowerPoint. So anyways, back to what we were talking about in regard to the cephalometric. You'll find that 21% of the population will have a compromised airway in a vertical position. So knowing that, we also know that 9 out of 10 children have an airway issue. So we anticipate that the balance of those children is probably a habitual issue. We also know that if we look at a child that is already compromised in a vertical position, this is the best it's going to be. So if that child actually is reclining or in a sleeping position, it can get worse. So when we look at it as just one of those tools that we have that aids us in that conversation. Now look at the child on the right. It has a normal airway. Well, yes, it's normal in the vertical position. If they're sleeping, can it be compromised? Absolutely. If they're a mouth breather, we know that about 6 millimeters of that airway is going to be compromised. So we look at this as a tool that we have. Now, we also know, we talked about if they have a normal airway, it also can be compromised just by a habitual problem, meaning that if they open their mouth a half an inch, that we reduce it by 6 millimeters. So this is the same patient, and you can see what happens just by the process of opening their mouth. Here's an interesting case that was treated with the HealthyStart. At the initial, we do have a way of determining age-appropriate airway development. So it typically is determined by the age of the patient starting at 5. You multiply it by 10 to get that diameter or that measurement of the airway. So this particular patient is a 9-year-old. So we anticipate 9 times 10, a 90 square millimeter airway. Now, in the initial, you'll see that the airway is 53.6 square millimeters. So we're deficient already to begin with. And again, same critique goes, it's vertical, it's not horizontal. However, it gets us into the ballpark. So here we already know we are deficient. So we use the first appliance that we use in the HealthyStart system, which is called the habit corrector. That patient wore it for 1 month. This is the initial 1 month. And we took a second CBCT scan in order to see what changes were occurring in that airway. Now, if you look at this within 1 month, now look at the CBC. It does have the appliance in the mouth, but look at the change that happened in the airway. We increased it 6 times. We went from 53.6 to 337 square millimeters. Now that's a home run. However, here's what really makes this interesting. As our airway develops, at age 17, we basically max out our growth and development. So at age 17, we anticipate our airway to be between 150 and 170 square millimeters. Bad news is at age 21, our airway starts to deteriorate over the course of our lives. So with adult sleep apnea patients, we never exactly know if they never reach their potential, or is that number not an accurate potential in order to carry us through our lives? We don't have the answer to that. But what I can tell you is if I look at this airway that is being created by a habit corrector appliance to measure 337 square millimeters, that's double what I would anticipate in an adult. Now, this is just the initial studies that we have started. We're actually starting a large research that's going to observe over a course of many children this development that is occurring. But we're also looking long term to see how much of this condition remains. Do we see deterioration? What kind of deterioration do we see? So this is a huge breakthrough, and this is an extremely exciting portion of what we're discussing, not just in our dental world, but in the sleep medicine world. And it could change everything that we talk about. And looking at these children, we're not looking at putting a Band-Aid on tonight and tomorrow night, which unfortunately is many times the case for an adult. There is no more growth and development. So we can make changes, but it requires cooperation each and every night. However, with a child, they have growth and development. So if we impact them and change that trajectory early on, we can make permanent changes for the rest of their life. That's part of the excitement of what we're talking about, and how this HealthyStart system is going to be able to address these areas, not just one isolated area, but the process of growth and development, the process of providing proper habits, the process of eliminating improper habits. This is tremendous, and this will change the conversation tremendously. So let's kind of briefly go over what that process looks like. So we talked about mouth breathing and snoring. We realized that it's created with extended bottle feeding and pacifier use. It causes poor tongue position and abnormal swallowing. Sometimes it's brought on by sugar processed foods. Also poor oral habits such as thumb, finger sucking, lip sucking, tongue thrusting, etc. From mouth breathing and snoring basically leads to a compromised airway. And with a compromised airway, we see reduced airway, restricted airflow, reduced oxygen. It increases the CO2. It affects brain function, immune and endocrine systems. It can create swollen adenoids and tonsils, low tongue posture, tongue thrust. It can create an underdeveloped dental arches, which create the overjet, overbite, and crossbite condition. And from a compromised airway, it leads into the sleep disorder breathing. And sleep disorder breathing outward symptoms includes a whole listing that's included in the HealthyStart sleep questionnaire. And these outward symptoms include restless sleep, ADD, ADHD, bedwetting, chronic allergies, nightmare, daytime drowsiness, aggression, difficulty in school, and frequent infections. And we discuss further in other areas. Let's take a look at brain function. It is interesting to look at MRIs of individuals that have a normal night's sleep versus those that have a compromised night's sleep. So if you look at the first 3 images, you will see this is an MRI of normal brain function with normal night's sleep. And you can see the activity. You can see the reds and the yellows that occur in this MRI. Now look at the lower 3. This is the brain function with an MRI with 1 night of sleep deprivation. I think we can see a little red right here. So bad news, good news. Bad news is, for all of you out there that pulled those all-nighters before your finals, bad choice. But this is an important concept to understand how the lack of sleep or the interruption of sleep can affect the brain function of an individual. So let's talk about HealthyStart. What we do, how we do it, why this is so critical. We have basically been working with pediatrics, growth and development for over 53 years. We've treated over 4 million children worldwide. We are the innovators of this technology. Dr. Bergerson is basically the founder, the brainchild. He has over 500 patents worldwide to look at these different areas, understanding the growth and development. He is an orthodontist and obviously taught at Northwestern University. He's written numerous articles, books, done research projects, and he still goes strong with the passion that he will make a difference in these children's lives. His goal is that every child is assessed and treated for this condition, and that we do not see adults later on in life experience sleep apnea or early onset of heart issues that occur at a later age. So the treatment of the HealthyStart includes different areas, and these areas are basically designed for certain ages. So we start with the youngest one, which is a toddler, ages 2 to 4. And with a toddler, they will only use 1 appliance at the onset, and this is the habit corrector. As we look at older children, say ages 4 to 7, if the child walks in, they will go through these 3 series. We will start with the first appliance, which is the habit corrector, the second one, which will help guide, expand, create the proper foundation of the oral cavity. And then the third and final will finish guiding the teeth in, allow those fiber bundles to develop into that position so there is no relapse. If you have a child that walks in that's older, say anywhere from 8 to 12, they'll use 2 appliances during their treatment. And they'll start with, again, the habit corrector, and they'll move into the second one that will help guide and straighten those teeth. We also treat adults. Our age span of our patients, our youngest patients are 13 months. Our oldest one is 84 years old. So we do the whole spectrum, but obviously we have to be aware of growth and development so that we are observing where we are in the growth and development of an individual and being able to address and to develop those areas that we can impact at that age of that patient. So HealthyStart will address the root causes, and these root causes include expanding the dental arches, establishing nasal breathing, training the tongue, eliminating bad habits, advancing the mandible to correct overjet, encouraging proper facial and body growth, and correcting most orthodontic conditions and problems. It's important to note that unfortunately, for so many years, we've looked at an orthodontic condition as a cosmetic issue. Many people might realize that functional problems within orthodontics can lead to other issues such as TMJ and TMD. But it is the linkage that when we look at an orthodontic condition, we should be looking at the overall health of that patient. Understanding if you see crowded teeth, it's just not cosmetically that we want to straighten them. Sure, straightening them to a beautiful smile is wonderful, but understanding that crowded teeth usually would lend itself to a narrow arch. If there's a narrow arch, that tongue cannot be in the proper position in the upper palate. If the tongue is not up in the upper palate and instead is laying low, the tendency is that it's going to lead to mouth breathing. If a child is mouth breathing, they're probably eliminating 6 millimeters of their airway, which will reduce the amount of oxygen that go into the body, which will therefore reduce the REM sleep, will impact the balance of the body, including the neurological, the endocrine, the immune. So you can see how this vicious circle occurs, but understanding that orthodontics is just not orthodontics any longer. It's basically an outward symptom of more important and critical health issues. So the habit corrector, let's talk about the first appliance. I get very passionate and I'm sorry, but I see way too many of these kids. I work as hard as I can work to get the word out to these parents. And just so you know, every Tuesday we do give a parent webinar to parents across the country. It is becoming more and more of a conversation piece for these parents. Typically when we give these parents seminars or webinars, we'll attract maybe anywhere from 1,000 to 18,000 parents on a webinar. And that's because we're educating them. We're teaching a parent what to look for. There's nothing worse than I meet a parent of a 22-year-old. And that parent tells me, I knew it. I knew there was something in regard to his sleep. I knew that ADD and ADHD wasn't necessarily the right diagnosis. So when we look at these issues, we realize how critical it is and how important it is that you as dentists, as dental professionals, are no longer the dentist to correct dental issues, but you're really an oral physician, and you should be looking at the overall health of those patients. So let's talk HealthyStart. As I said, it is a series of appliances that are used to utilize and to change and to promote the proper foundation for the oral cavity, but also the proper habits. So the first appliance is very targeted on habit correction. And how it works with this is that the appliance actually has built-in myofunctional therapy. Now, there might be people who say, oh yes, we use myofunctional therapy in association. And there is absolutely nothing wrong with that. Unfortunately, the statistics are cooperation with myofunctional therapy is dismal at best. The last research had it at about 1%. That's not going to change it, right? We could go into myofunctional therapy. If the kid isn't doing it, the kid isn't getting the changes that he needs. So the way the HealthyStart is developed is the HealthyStart actually incorporates that myofunctional therapy within the appliance. The patient is wearing it while they sleep and just activated by the swallow. So at night, we swallow 1 time a minute. During the day, we swallow 2 times a minute. So just by using the HealthyStart habit corrector at night, we're repeating the proper swallow, the proper position of the tongue, the proper breathing, the expansion of the arches over 500 times each and every night. That's huge. Myofunctional therapy, if at best we get 200 repetitions, that's a home run. We're getting 500 a night. So if the patient is wearing the appliance, there is only one way they can swallow. There is only one way where that tongue can be. And we're accomplishing 500 repetitions each and every night. So here are the features that we use. So we have these palatal tabs that are located here, and the tongue spreads out and puts pressure on them so it expands the arches. We have a lingual shelf or a ramp. So every time the child swallows, that tongue is lifted and positioned up in the palate of the mouth. At the same time, we have these prongs here. So if a child tongue thrusts, it will prevent that tongue thrust. But also, as a child swallows, once they hit that, they know the tongue is retrieved back. So it is an indication to help encourage the proper swallow. We also have two little tabs here, and those are positioned in the lower. So a child will not have any opportunity for that lower chin to drift back and impact that airway at all. So these are some of the features. We also have a pull tab that can be used to pull on the appliance to strengthen their lips. They are going to seal their lips around the outside of the appliance. It's going to be difficult, especially for the mouth breather at the beginning. So the idea is they go and continue and continue. This little pull tab gives them basically a goal of what to hit. Some patients are fine just by touching the lower to the upper lip, but this way it helps encourage this as well, and it helps put it on to the bedclothes, because at night, especially if you have a very prevalent mouth breather, and the mouth breathing can occur just at night or day and night, especially the ones that are day and night. So to begin with, it's going to be a little bit more difficult for them to hold that appliance in their mouth. We know that. We are going to basically each and every night work to improve that number. What we typically see is, say for instance, it stays in 2 hours the first night. Maybe the next night is 2 hours and 15 minutes. Maybe the next night is 2 hours and 30 minutes. So you see the progression. If a child, we have children who have Down syndrome, we have children who have autism, we notice if they're having difficulty keeping that in. Sometimes I hear, oh, we got a gagger. Well, let's think about that. Why do we have a gagger? Well, the reason why we have a gagger is because their airway is already compromised. They're extremely nervous that you're going to cut off whatever airway they have. So they're already compromised. So sometimes to reduce the anxiety of putting something in their mouth at night that they're fearful of, we might have them only wear it an hour during the day. We say maybe 2 weeks, have them wear it an hour during the day. And we get them so their body is used to it, they're relaxed, they feel the difference of expanding and enlarging that airway. Then we can introduce nighttime wear. So we're always working. Realize that HealthyStart, we're a collaboration with your office. I'm not here just to say, here's this appliance, here's that appliance. That's not the deal. The deal is we're working with growth and development. And we'll talk about how we implement and we work with your team. We look at the cases. We have certain parameters, certain specifications we are looking to identify and measure so that we're doing the very most for each and every patient. How do we look for a proper swallow? How do we identify that? It's pretty easy. Typically, I would have a cup of water at every chair side for every patient that comes in. Have them take a glass of water. Tell them, wow, you must have had a really rough day today at school. Take a glass of water. You probably are thirsty. Watch how that child swallows. You should only see movement of the neck. If you see the facial muscles move, perch their lips, any of that, that means they're trying to compensate for a lack of proper swallow in order to swallow that water. So what we monitor is, as a child goes through the HealthyStart treatment, each month we're going to watch how they're swallowing and seeing the improvements of that swallow. So it's an easy way to identify and an easy way to identify the correction that is occurring as well. We talked about the rates of swallow, 1 time a minute at night, 2 times a minute during the day. Here's an interesting study that was done on 220 HealthyStart patients. And we looked at the different percentages of the different outward symptoms they had and looked at the percentage of correction that occurred. So let's take the first one, headaches. 40 patients out of the 220 exhibited or indicated headaches, and that represents 18%. Out of that 18%, we had 98% of the cases having improvement, 94% mean correction of those with improvement, 91% mean correction of the entire sample, 85% of the cases with 100% correction. So you can go through, and the reason why this is so critical is as you have patients that come in, we want to give a parent an idea of exactly how much correction is going to occur and within a 5-month period, and then going from there. Let's talk about ADD and ADHD. It's one of my favorite topics because I think misunderstood and obviously so prevalent. I think every child, it's an exaggeration, but it seems like every child has something, or the parent indicates thinking it's ADD and ADHD. Child has problems focusing, their behavior in school, things like that. What's interesting is ADD and ADHD is not a blood test. It's obviously a list of criteria that has to be fulfilled in order to have that diagnosis. What's interesting is sleep disorder breathing has the same list of criteria. Can they be misdiagnosed? Absolutely. Our stance is, if you suspect ADD, ADHD-like behavior, investigate the sleep first. Address the sleep first, then see where the child is. I can guarantee you we will minimize, or it might be 100% of the reason of these issues. So it absolutely does the child no harm, only benefits them to address this and look at it more seriously with this kind of issues. There are some very large studies that were done on ADD and ADHD. Karen Bonnick is probably the most prevalent. She studied over 13,000 children. Her results included sleep disorder breathing increases the risk of ADD and ADHD by at least 50%. ADD and ADHD patients have little or no REM sleep, but have delta sleep. Patients without ADD and ADHD have primarily REM sleep and delta sleep. And ADD and ADHD was present in 25.2% of our research that we did on those sleep questionnaires. Here's some unfortunate statistics, but I think it's important, and maybe this is something that's shared with parents as well. We find that children that have been diagnosed with ADD and ADHD, 50% are held back 1 grade, 30% are held back 2 grades. My comment to that is, if that child is actually suffering from sleep disorder breathing, you could hold them back 10 grades, and it is not going to make the difference. You again have to look at the underlying root causes, and identifying and evaluating and treating for sleep will only help that child. If a child does have sleep disorder breathing, we see that IQs can be impacted by 10 to 20 points. And the research that evaluated that even went so far as to evaluate the value of an IQ point, which was seen to be $170,000 during the course of a lifetime. So let's talk about how HealthyStart promotes growth and development. As we look at craniofacial growth, we know that it occurs probably between 0 and 12. 12 is kind of our cutoff, and it's skeletal rather than chronological. Kids develop at different rates. But the reason being is, at 12 years of age, 89% of the males have already reached their full craniofacial growth, 94% of females. You can see how the growth and development occurs. It's forward and down. These appliances, the HealthyStart system, is going to mimic that growth and development. And it is going to utilize that growth and development in order to promote the growth and development that is available for that child. We do not want to miss that opportunity, because once it's missed and growth is completed, it is very difficult, if ever obtained, at a later time. So here are some cases. Let's look at the before and after. The child on the left is a 5-year-old. Obviously, look at the deficiency. If I draw a line down the front from the forehead down, you can see how deficient she is in that lower third. You can see the overjet tendency, or the retrognathic tendency of that lower jaw. Look at the circles under her eyes. Take a look at the child now. She's a year and a half later. She's 7 years old. And look at the change. We actually received 54% more mandibular growth And research indicates, we did a study, one of the largest orthodontic studies in Finland, and they found that they received 54% more lower jaw growth with the HealthyStart system than with controlled children during their growth and development. So it's really an amazing treatment, easy to use, but so effectual in promoting that growth and development. We also have other appliances that also can aid us in that growth and development. So if you see a deficiency in both the maxilla and the mandible, we're able to promote both in a forward growth and development because the appliance has no front wall on it. It basically is open, so it drives that upper arch in a forward direction by utilizing the tongue against these tabs. At the same time, the lower portion of the appliance brings that lower arch again in that forward direction. It happens very quickly. You can see from the initial 1 month current. Typically, we say it lasts about 4 months. So you can kind of gauge. It depends on the wear of that patient and how well they do it. Here's a class 3 occlusion. Obviously, we know there's 2 types of class 3. There's a skeletal and there's a pseudo. How quickly you tell the difference if a child bites into the occlusion, into the class 3, typically skeletal. If they bite end to end and slide forward, typically pseudo. We can correct any pseudo. The skeletal, we can minimize. So again, same principle, no forward portion on the upper arch. The tabs are utilized by the tongue to drive that arch in a forward direction. The lower portion holds the lower arch stable as we make the jump. Typically, the jump occurs within 2 to 4 months. We do have a patient that actually worked 23 hours a day and was able to correct their pseudo class 3 within the weekend. So it does go very quickly. Treatment planning, I talked about looking at different areas. We want to understand with you and help develop a treatment plan that can actually look at the deficiencies, look where we can make a difference, and come up with a treatment plan that will promote as much growth and development as possible. So let's take a look at some cases. This is always fun. Like everybody else, we love to see before and afters. So I'm sorry, we're starting our winter months, so it gets very dry. I'm in Chicago, so sorry about my voice. Here's a child, 7 years of age. What's interesting about them, he did have his tonsils and adenoids removed 2 months before this sleep questionnaire was filled out. Obviously, you can see it did not make any difference in his situation. His parent indicated that he had, I believe it's 17 outward symptoms. You can see 5s, you can see 4s. This is a serious case. He initially started the first appliance in the HealthyStart system, and we had this filled out 2 months later. And you can see, I think there's 1, 2, 3, 4 ones. I mean, amazing the changes. We've significantly reduced this area. Look at the speech area that this child had. The parent indicated very delayed speech, didn't say many words up until age 3 or 4. Again, tongue not in the proper position, can't initiate sounds. That changed as well as they began to accommodate where those sounds could be initiated from. So here's the child at the onset of treatment. He doesn't look too severe. I mean, not some of those features that we tend to immediately identify, but let's take a look. Look at slight circles under his eyes. Let's take a look at the proportion. We should have equal 1/3 upper face, 1/3 middle face, and 1/3 lower. If you look at this, look how deficient this lower face is. Look at the profile. Take a look at the arches. Look at this, an extremely deep overbite. You can see the arches are more square shaped. And this is March of 2015. Remember, he wore the habit corrector for 2 months. We saw most of those habits diminish. But now let's look at what his facial structure. Let's look at the growth and development and look at the changes of the orthodontic condition. 1 year later. It's really remarkable. It's hard to even identify that as being the same child. such a difference. Look at the proportions of his face, a third, a third, a third. Look at that overbite, eliminated. Look at the squareness of the arch is now rounded. Look at the rounded arch. Now let's take a look a year later and see how stable this case has remained. Nice occlusion. Look at how the teeth, deep bite, all corrected. Nice alignment. Look at the arches. Rounded, beautiful. Intercuspation of the teeth, beautiful. Now let's take another case. You can see has outward symptoms. 2 months later, you can see that they've been reduced to zeros, mostly zeros. Here's a 1. So obviously in 2 months period of time. Initially, very deep bite. You can see in progress how that deep overbite has been corrected. Here's an initial patient. You can see obviously a lot of orthodontic issues going on here, deep bite. Here's the finish comparison. Here's the process. You can see the appliance in the mouth, deep bite. You can see how those incisors are coming in rotated. The appliance captures them and brings them into a line, allows them to erupt, allowing the fiber bundles to develop into that position. So we have kind of that retainer for life. We also have the proper position. We're not going to see a tongue thrust basically relapsing that case. We're not going to see mouth breathing relapsing that case. So those are some of the areas that are going to help stabilize this case, but obviously correct the other health issues that have occurred. Here's the beginning to end. Here's another one, initial to finish. Here's an interesting case. This parent of this child was 37 when she had surgery. And obviously, surgery is a great ability to correct something, but obviously, if we could prevent surgery, we would like to. So as she was looking at her young child, she realized that child had the same characteristics she had as a young developing child. So she brought her child in. You can see deep circles under her eyes, deficiency in the lower third, rolled lip. Look at the deep bite. She has a lot of wear and tear on her teeth, obviously a bruxer. We see square arches. So here she is now. Let's see what she looks. And this is approximately 2 years, maybe 3 years later. Totally different child. Take a look at a third, a third, a third. Look at her profile. Look at the roundness of her arches. No deep bite. Now let's see how stable this case is. Here she is. You can see how the case has settled. You can see the roundness of the arches, beautiful facial structure. Let's see even further. Same deal, maintains roundness of the arches. You can see how beautiful her features are. Here's another case, snored, brux, bad breath, ear infections, about a year later. Here's another case, outward symptoms, reduced in 2 months down to zeros and ones, deep overbite. You can see squareness of arches. You can see how the case is progressing. This one is not finished, but you can see how the progression is occurring. Another one, spectrum, snore, brux. Here's mid-treatment. Here's now 14 years later, stable and beautiful. We do have an app that goes with each patient, with each case. It monitors, obviously, cooperation, compliance. It rewards the child. They get coins. They get game time. But every Friday, we also have them take a selfie of themselves. We give them cheek retractors. So we almost have a flip book of exactly what that occlusion looks like. What makes this so unique is all that information is also sent to the provider's office. So during the 6 weeks that you do not see your patient, you know exactly what they're doing. When they come into their appointment, you're able to obviously have a totally different conversation because you've seen the progress of that case, and now you have that conversation with that child. As I said, over 4 million cases worldwide. Our appliances, we treat our patients like we treat our own children. We have the safest appliance on the market. It is FDA cleared. We basically regulate ourselves to a class 2 medical device, even though we do not need to. It's safe enough to go within the body. There is no latex, no plasticizers. All appliances are BPA, BPS free, phthalate free. There's no silicone. These appliances have been used in 53 years. We have no incidences. Susie, I don't know if we have any questions. Maybe we can address those. And I know you have a little bit more to discuss about what they can do at this point to move on and complete and continue this education.
Yeah, absolutely. So at this point, there's not any questions. So what I'll do is I'll go ahead and tell you guys a little bit about our education program. But what I'd like to encourage is please know that you can still ask questions. So what you'll want to do is you'll want to use the little Q&A button on the Zoom platform. So if you click there, it'll bring up a little box where you can ask your questions. So anyway, just wanted to mention that. So if you have any questions, please ask them. But in the meantime, you know, I want to tell you about our education program. It is I have to say, the best education program out there. And one of the reasons why it's so great and we get such amazing feedback on it is because it's a 3-pronged training. And what I mean by a 3-pronged training is it actually encompasses a digital course, it encompasses hands-on training, and it encompasses actual live classroom training as well. So I'm going to tell you about the digital portion first. Our digital education series is 7 sessions. Now, the way that it works is we actually send out a video every Monday for 7 weeks. The video is about an hour and a half long, and it goes over different things, as you can see, like, for example, sleep disordered breathing, or the oral habits associated, you know, things like that. You have the entire week to watch this video series. So you can, it's at your convenience, at your leisure, and you can ask questions, you can write down your questions, those kinds of things. And then on Friday, we have a live interactive study club. Now, the study club is fantastic. We actually have a trainer on every study club that goes over different you know, the highlights of the video that you watched, but also we bring on a specialist every study club. Now, the specialist goes over things like organizing HealthyStart in your office, how to talk to the parent, you know, how to take care of your billing and your financials, you know, things like that. You know, how do you reach out to the community and let the community know that you are now treating children for their sleep and breathing issues, and you actually have a treatment program system that can help their children. So we go over all kinds of different things like that in the study club. So we encourage not just you, but all of your staff members to attend as well. Now, as I mentioned, it also encompasses a hands-on training, and the reason for that is because we actually give you 2 entire systems for 2 children. So we give you 2 age groups. So we give you a 4 to 6-year-old system, and we give you a 7 to 11-year-old system. And the reason for that is that way you can not only work with 2 kids, but you can actually treat these 2 kids while you're taking the course. So we're going to teach you how to submit the case. We're going to teach you, you know, how to pick the best, you know, the best patients for your first patients. We're going to just everything that encompasses you working through from start to finish these 2 cases. We'd like to kind of walk you through that whole process. And that's going to include all of the appliances that they need. That's going to include our doctors looking at the case and us sending you back a full evaluation treatment plan. It's going to include specialty appliance cases for the kids. It's going to include the HealthyStart mobile app that Leslie was just talking about. So all of that is included in that hands-on treatment of those 2 full cases. You can also attend any of our live courses. We have a great, really great schedule for 2020. I'm excited about it. But anyway, you can attend any of those live courses, and that's all included in the course. So it's a 3-pronged training, and you can actually bring 4 of your staff members to the live course with you as well. You'll also receive a sample acrylic stand. Now, the acrylic stand's really neat. It has, it comes with samples of all of our different appliances. So, you know, as you're talking to the parent about the system, you can show them, they can feel it, they can show their child. It's really great. Now, we have a course that's actually starting on November the 11th. So this is perfect timing. And the great thing about this course is it actually complements the ADA policy, basically stating that, you know, Every dental professional needs to receive the education on how to treat children, how to assess children for sleep and breathing issues. So this course actually complements that policy. Now, on top of that, as I mentioned earlier, you're going to receive all the training that you need in reference to sleep-related breathing disorders, how to identify it in your patients, how to increase your patient flow. I mean, we're really all about patient education. So we're going to help you, we're going to help you understand all the different ways that you can help educate your parents. And we're going to provide you just a ton of different things, everything you need for your website, marketing materials, just our goal is for you to be successful because if you're successful, then you're helping children. And there are so many kids that need help. So, that's our goal. Now, this course is great because you actually earn 18 CE PACE credits. Now, that's for the digital portion. Then you earn 16 more when you attend a destination course. And the digital course includes you and all of your staff members, which is fantastic. So there's no extra cost, and you can include all of the staff members. The live course, it's you and 4 of your staff members, and then you have those 2 cases as well. Now, we have doctors that attend our course all over the world, and that's what's great about this is no matter where you're at, you can attend because it's digital. So I want to tell you a couple of things that we've heard from some of our doctors. So we had a doctor in Australia who attended our course. He actually said that the course was excellent. All at HealthyStart have really got their act together and offer resources others strive for but rarely achieve, well organized, passionate, and supportive. Doctor in Canada, I want to thank you and your colleagues for this amazing course. I've been searching for a solid system to help my patients, and this is by far the best, most organized, comprehensive course I've taken. A doctor in Colorado, she said, I've really enjoyed this course. We've identified quite a few patients that will benefit from HealthyStart. My business partner's 4-year-old is in the habit corrector because he's had swallowing problems, and we've already seen great improvement in his eating. And we have 3 more patients ready who will be starting next week, and we can't wait to see their progress. And I really love that testimony because Dr. Wright was actually only 3 weeks into that 7-week course. But that's how it works. I mean, we send you those habit correctors, the starter appliances immediately. So you have those 2 appliances. You start taking the course, you can hand those appliances out. I guarantee you the parents are going to see the changes in their children. They're going to see healthier kids. They're going to see their children waking up in the morning feeling better. They're not going to have the headaches anymore. They're not going to have those symptoms that, anyway, it's really awesome. So they're going to reach out and they're going to talk to other parents. That's what parents do. You see your children thriving, and you want to talk about it. So that actually leads other parents to find out who you are, and then they want their children to be seen as well. Now, the American Dental Association actually took our course, and they said that it was ingenious, which I think is pretty high praise from the American Dental Association. Okay, so key financial metrics, your startup cost analysis. So typically, the digital education course is $3,400, and that includes your entire staff. The in-person destination course is $400, and that includes 3 staff members. Now, that's a pretty good deal already, I think. Anyway, that's a pretty good deal. But being that you attended this webinar, and many of you actually attended and met us at some of the recent events that we were at, we are actually giving you this course. The digital education course is $3,400, and we're going to actually give you the in-person course at no cost. So that's why I say it's a 3-pronged training, because we're actually giving you all of these different aspects of the training for just the cost of the digital course, which I think is pretty awesome. As I mentioned, you can get started immediately. We will send you out a welcome package. You'll receive a package in the mail that'll have your starter appliances. It'll have your cute little cases to put the animal cases or the appliances in. You'll receive your acrylic stand. You basically receive everything that you need to get prepared for the course to start on November the 11th. So how do you get started? Simple, Simon. You can, number 1, visit us at openairwaydentistry.com. This is the best and easiest way to get started, because you'll see these little green register now buttons on the page in several different areas. Just click one of those register now buttons, and immediately you can just fill out the little form, register, and that's it. And then we'll receive your registration, and we'll reach out to you with that welcome package. And I mean, gosh, we really you really become part of our team. So, and so it's really fantastic. Now, you can contact me directly if you have additional questions or if there's anything that you'd like to ask or talk about. You can reach me at slafredo@thehealthystart.com. So anyway, I noticed that there are some questions that have shown up since I've been chatting. So I'm going to pull up those questions. And Leslie, do you mind maybe coming back on again, and we can do some Q&A?
No, I'd love to.
Okay, great. So one question is, now this is one that I know we will actually really get into. We have a specialist. Her name is Glenine Varga, and she works with us with Healthy Start. And so she does an amazing overview in reference to this. But the question is, how can we bill for Healthy Start?
Such a great question. So there are two ways you can bill for Healthy Start. Well, actually three. But obviously, you can do a fee structure that a patient would directly pay for the services. We are covered under dental insurance as long as there's the orthodontic component. We have never been refused by the dental insurance with the orthodontic coverage. With that, unfortunately, maximum coverage is anywhere from about $1,000 to $2,000. So that would basically reduce that fee that you would be charging. I don't think we talked about typical charges for that. We hear probably around $3,700. So that kind of gives you a parameter of what this looks like. We also have been working with medical insurance. Obviously, with medical insurance, we're probably 40% successful at this point. Medical insurance has not been as advanced in looking at pediatric sleep issues as they have with adult. It is a progress. We tend to look at the medical area in twofold. One as sleep issues, but then on the other side, we might look at it as handicap malocclusions. Glenine Varga is a wealth of information. She is available. She works with Healthy Start providers to have that conversation on how to address those insurance needs.
Awesome, thank you. Okay, next question is, what is the reason for bruxism without mouth breathing or with mouth breathing, and how can it be corrected in children?
Okay, so bruxism is actually is an outward symptom that is created because of sleep issues. So as we talked about before, mouth breathing does contribute to the sleep issues because it reduces the amount of oxygen. So as we begin the Healthy Start system, we will look to see that oxygen is increased because we are basically putting the habits in the proper position, but also the oral cavity in the proper position. So as the treatment progresses, we see the bruxism eliminate. So it goes twofold. So we see it in combination. If you see a young child that's bruxing, I would definitely take that as an indicator to look further on to other outward symptoms. I will say we are right now, it's actually being completed. It was a large study in Brazil where they looked at kindergarten kids in various schools. And they wanted to use an easy mechanism where a parent could identify. So they used bruxism. And what was interesting was the study found that majority of those children all bruxed, even at that young age. And when they used that as the first indicator, then they were able to look further and determine the other factors that were already contributing to the sleep issues.
Sorry about that. Took me a second to unmute. Okay, so next question is, do impressions need to be taken for the devices to be made for each patient, or is it a standard mouth device for each patient which doesn't require impressions or lab work?
That's a great question. So basically our appliances are what we call preform, but they come in a variety of different sizes and they address different ages, different skeletal development. So when we look at a child, we, through our expertise and evaluating literally millions of cases, we are able to dictate what that future dentition will look like. And what we're doing is basically predicting it so that we ensure that what occurs in nature actually occurs. So we know already that in this generation, 92% of malocclusions will occur, meaning that the teeth do not erupt in straight. So we can already anticipate that. So when we look at a case, we're going to have you provide us with models, digital scans of the oral cavity, so that we can help evaluate where that child is dentally, and then provide you with the proper combination of appliances in order to successfully guide that growth and development to the ideal or to the maximum amount of growth that can occur in that child. So even though they are preformed, we call it more of a custom type of treatment plan that occurs that is unique to each and every child.
Awesome, thank you. So next question is, and I'm going to combine actually two questions, but how does HealthyStart compare to some of the other companies out there, like for example, MyoBrace or Vivos?
Great question. So I'm just going to be 100% honest. So HealthyStart by Orthotame was the originator of this form of treatment, of this identification, of providing appliances that promote growth and development. Unfortunately, MyoBrace was actually our distributor in the Netherlands, not a dentist, not anything, just obviously a distributor that was trying to mimic what we did. Unfortunately, they weren't able to mimic our proprietary type of treatment. So in essence, we promote growth and development. What happens with a MyoBrace type of appliance is basically it is one piece of a plane. So when a child bites down, they bite all their teeth down at the same time, which deepens the bite and can lead to TMJ. They also don't understand growth and development, so the appliance or the patients typically end in an end-to-end or a class 3 condition, which obviously is what we're trying to prevent rather than encouraging. The materials that are used basically crumble and can cause aspiration. The appliance, the MyoBrace is manufactured in Taiwan, which has less restrictions and this and that. So basically, be very careful. The appliance that is supposed to treat TMJ is not, it's TMJ, it's tooth, mouth, jaw. It has nothing to do with TMJ. Actually, the way their appliance is designed, it actually increases the possibility of a TMJ because it's deepening the bite. This will not happen. If you look at ours, look at our final cases, it's intercuspated, the teeth align perfectly. We correct overbite, overjet, open bite, gummy smile, cross bite, class 3, all at the same time. These appliances are designed so that we correct the problem. We're not just looking at the habit. The habit is one component. As we talked about the underlying root causes, you have to expand the arches. We're looking for that expansion. You have to correct the habit. You have to look at the growth and development. And frosting on the cake, we're going to straighten the teeth. Ask for before and afters. Vivos unfortunately was my marketing people that decided to try to go into this same arena. They have, I think, only 2 appliances that they have. And again, they don't understand growth and development. They don't understand how that progression occurs, how those, I don't know. I've never seen a finished case, so I don't know if you have. I don't mean to be negative, but the problem is it diminishes what we do. When people go in and they use other systems that don't give the proper alignment, the proper correction, say what they're going to do, people tend to think we're all created equal. We are not created equal. I would challenge anyone that uses any of these others to look at theirs compared to ours. And I will have that conversation at any point in time to discuss it with you, because it is so imperative. How many years, how much research, how much dedication it has taken to develop and to basically come up with this linkage that is so amazing is critical. But then to understand how growth and development, how that progression happens, and be able to promote it. Look at the research. There is not research on these other products. If you look carefully, it's typically our research, and they kind of change the name. So just be extremely, extremely careful with what you do and how you're doing it. Realize that when you come on board with HealthyStart, you're not just a customer. You're basically our teammate. You're part of our family, because we are going to work closely with you, and we are going to be your advocate as well as you being our advocate. And that partnership is critical in order to take this conversation that we're having tonight and take it to where it needs to be in the dental profession. This conversation in regard to sleep, breathing, airway, the overall health of a child should be the biggest thing that happens in dentistry. And I know it will be. I know how many children are affected. And I know we have an absolute unbelievable way of addressing it, but also treating it. So a long-winded conversation, but I am really passionate, and I would encourage you, if you want to, Susie, I'm more than happy for you to give my personal information. Please reach out to me if you have any questions in regard to this.
Awesome. Thank you so much. Okay, so for the course, what CE credits do you get? And I can actually switch back up really quick if you'd like. But so in the course, you're going to receive 18 CE PACE credits for the digital portion, and then 16 more when you attend a destination course. So it's actually great timing. Okay, next question is, I am an SLP and have experience with the Meyer Research appliances. How can I access this appliance?
I think you're talking about, so SLP is a speech language pathologist, which we were talking about, and we've worked closely for the past few months in creating, I actually have a new sleep questionnaire or speech questionnaire that I would love for you to review. So I don't know who you are, but if you could reach out to Susie, maybe we can share it, take a look at it, give us your feedback. How do you access the appliance? What we have been doing is working in collaboration with the speech pathologist. What we would like to do is have them be evaluated within a provider's list. If you go to our provider list within our website, you can send an email to us indicating where you are. We will give you a list of providers. And then they will work in unison with you, because as they wear that habit corrector, you will see the progression of these speech issues. The proper position of the tongue, the endurance of the tongue, proper lip seal. These are all such important characteristics within what you amazingly do with these kids. And obviously, that collaboration will be so key, not only just for the speech portion, but then looking further down the road to access the other deficiencies that that child is probably enduring. You're more than welcome to take that sleep questionnaire as well as the speech, and have that patient fill it out, and then we can obviously assist you in providing you with a provider in your area.
Awesome, thank you. Okay, so next question is, have there been studies on patient compliance when wearing the HealthyStart appliances?
Yes, actually, there were two large studies. One was in Finland and one was at Tufts University, and they received 94% cooperation with these appliances. Sometimes I say we're even better than that research was back then. The patients actually just wear it. Most of them wear it passively at night when they sleep. So the compliance portion of it is very easy. What makes it kind of interesting is the child feels so much better. Many times we think of compliance orthodontically, kids wearing rubber bands, compliance, kids wearing retainers after orthodontic corrections. This is slightly different. This is, yes, they are going to see an orthodontic correction, but more importantly, they're going to see an overall improvement in health. And those kids feel better. What ends up happening typically is when it comes to the end of treatment, those kids have a lot of difficulty giving up the appliance, which is a great problem to have, but it's an interesting compliance. We do have different criteria of how we speak to a child, how we motivate a child, but also we look at the parent. Sometimes we say compliance issues is basically an uncompliant parent. And so we want to make sure that the parent is part of the process. If they're not on board, if they're not seeing these issues, that's probably not a parent you want to partner with. We want a parent to understand we need to have that collaboration, because obviously we need that child to come to appointments. We need that child to wear the appliance at night and, to work with the app. So if you don't have that participation, that's going to be difficult. But the research has indicated 94% compliance.
Awesome, thank you. And so this, I'll ask this one, and I think I'll actually take care of several people. So the question is, what is the fee structure for additional cases after completion of the course, so after the 2 free courses, and is support subscription based? That's a good question.
Okay, so so obviously, if you start the course, you get 2 free cases, and that is from, beginning to end. In regard to what the lab fees are for these cases, it's basically either $600 or $700, and that includes either 2 or 3 appliances that will get that child through that treatment. It will be the treatment planning. It will be progress checks. It will be any type of support that you need with these cases. It includes the app for each patient. We basically also work with you for parent information, provide brochures. It's basically all the details that you need for that case. Once you start, we do, sometimes doctors want to have the first appliance in their office so that they can get started right away and submit the cases. If that occurs, that appliance runs $125. There's obviously, if you order more of those initial appliances so that you're obviously starting them out and then submitting the cases, that number comes down slightly. Is it subscription based? I'm not sure exactly what you mean by subscription, but yes, you need to basically go through the course in order to understand the process, understand how we're identifying how these cases are being processed. And once that occurs, then yes, each lab fee will occur for those patients.
Yeah, and I think maybe the question or what she's asking is our support. So, I mean, our support is actually, so once you actually turn in a case and you have ordered that system for that child, we actually, our customer service is pretty amazing. So, for example, you can actually turn in a progress check. Let's say it's 6 months down the road and you're wanting to have another look, for example, on that particular case, how things are going. You can actually send in a progress check to HealthyStart. We'll actually have our reviewing doctors take a look at it and we'll send you back an evaluation. So we have great customer service, and we do have implementation specialists. We have internal provider reps. We have, I mean, we're pretty hands-on as much as you'd like for us to be, but we are really all in helping to ensure that you're successful. And our customer support is not subscription based, but only the cases, turning the cases in, of course, would require the lab fees, which is how you get your appliances.
Right. I think once you've become a HealthyStart provider and go through the course, you're part of our team. We're part of that collaboration that makes your office work. And we are here to support you. You're successful, we're successful. If we're both successful, we treat many children. So I'm not here to tell you, I don't know, I've heard, $90,000 in order for you to be able to use this. We're not that way. Basically, we want to support you. We want to make this the best system that is available for your patients. And hopefully after 53 years, we have a little expertise in this field. We've treated over 4 million children. So we kind of understand what works, what doesn't work. I would never say I've seen everything, but I've probably seen majority of what's out there. So we have a lot of information that will make you successful. We have cases that come in, the kid's missing 8 permanent teeth. That's a difficult case, but let's help you. We have orthodontists on staff as well. So we're working as a team to kind of figure out the best way that we can work with that child. If you've never had experience in orthodontia, you're like, oh my gosh, I can never do this. We will guide you through that process. We are always evaluating how much knowledge you have, where you want to go, your desire to improve your expertise. Let us help you do that. So we're working with your comfort level, but then also working with your patient pool and being able to help you through that process. So I hope I made you relaxed. I really hope tonight is the night that you look at this as such an opportunity to grow your practice, but more importantly, such an opportunity to change your practice and change your community and help these kids. So whatever we can do to assist you, we're here to do that. I have made it my mission. Susie's here late at night at the same to help you. So I appreciate all of you spending so much of your time tonight listening and learning. The questions have been amazing. Don't hesitate if you have more questions. Sometimes our biggest or our best questions come in the middle of the night, and unfortunately, we're not sleeping soundly, and all of a sudden we have an interruption. Write it down. Call us in the morning. We'll be more than happy to answer it. Yeah. I see some of these. I'm ecstatic. We have been reaching out to a lot of MDs, medical professionals. They're on board. They're looking for you as a provider to help them because they don't have the answers for these kids. And they see the potential. The response has been amazing. Most of our research projects are a collaboration with sleep physicians, MD, pulmonologists, cardiologists, ENTs, as well as dentists, ortho, and pediatric specialists. Looking at the speech element, speech pathologists, I'm ecstatic beyond belief. We are working with nutritionalists because we realize there is a component of that that can help us maybe with some of our more severe cases. I see dental hygienists. That is amazing. You are the first line of defense. You see these kids day in, day out. You see this. It gives you a great opportunity to start that conversation. I see an oral therapist that's on here. Another great area. You realize the deficiencies you have. If you can incorporate this along with your myofunctional therapy, how great is that? How beneficial will it be for those patients? I'm trying to look down the list, and I'm ecstatic with all the variety of people that are here tonight trying to absorb this information. So thank you. That's all I can say. And I don't know, Susie, if we have more questions or.
Well, actually, just a couple more that I'll stress really quickly. I know they just.
I'll be here all night.
This is a great group. Well, a couple questions I just wanted to address really quickly. One is Dr. Park is just asking. Yes, the $3,400 does include the 2 free cases. It includes the live course. It also includes, yes, we'll send out actually to all of our doctors who attend the course. We actually provide you with a parent presentation so that you can actually educate the parents in your community. So yeah, all of those things are actually included in once you become a provider, but those things are included in the course, absolutely. Yeah, go ahead. Yes.
Also, there is displays to put in your office. So many times the parent says, show me what it looks like. Let me feel it. Let me see what that is about. And that will also come to you as well. We also I've been getting more and more requests for medical presentations that they can bring to their local pediatrician or to the ENT or to the sleep physician. in the area. They have grand rounds that doctors have gone on. One was just invited to University of Indiana to speak in front of 200 pediatricians. So we provided them with a presentation as well. So all of those, there is no charge for those. We want to obviously continue that education.
Yes, thank you so much. And then there's another question, where do we find our CE course code? We'll actually email you. So the list of everybody who attended, we will email you your CE information certificate within the next, tomorrow's Friday, so at the very latest by Monday. So you'll have that in your email.
Tomorrow's Thursday, unless it's
tomorrow's Thursday. Oh my goodness. Yeah. Okay, so maybe by Friday. Totally off. So yeah, I think there's just two more questions. One is CBCT. Is that something that's required? And then the last one is, by any chance at all during the course, do we talk at all about tongue tie?
Oh, awesome questions. CBCT is not required. Obviously, it's a tool that we can use. It's an expensive tool. So no, we don't need them, but we provide you with a lot of data of those patients that have had them. So that can also be used as an illustration to a parent to show them without having exposed them to the radiation. Just so you know, CBCTs are actually less radiation than a Panorex. Usually 2 CBCT scans is the equivalent of 1 Panorex, but no, it's not required. Tongue tie is a huge issue, and yes, we do talk about it. Obviously, it impacts kids. We are in the process of a study where they're using it after a release in order to train the tongue. And these are on very, very young children, but it can be used in any age. So yes, it is definitely something we talk about. I don't know if the person who's asking this has expertise in it. I'd love to further discuss with you what you're seeing. We hear a variety of different comments, how many kids are truly effective with the tongue tie, how many kids we're addressing. So anyways, I'm always interested in learning more about it, but we definitely do address it in our course.
Awesome. Thank you so much. So I want to thank you guys so much for, gosh, your participation has been fantastic. We appreciate all of your questions. And I wanted to just remind that, now is the time. Once you hear this information, you can't unhear it. You can't unknow it. So every child that you see, every child that walks into your practice, and now you know that there is a system that can help. There's a system that actually treats the root cause of this problem. It's not a Band-Aid. It's not, covering up the symptoms and so that the child feels better, but doesn't actually fix the issue. I mean, I think that's what's so amazing is that this system gets to the root of the problem and addresses it and treats it. And so to know that that's available and that you have the opportunity and the tools to be able to help these kids is huge. So, I just wanted to mention that again. It's as simple as, again, visiting openairwaydentistry.com. You can join our certification course and then start your journey. So thank you guys so much. I really appreciate your time, and we will send out your certificate very soon. And Leslie, thank you also for spending your evening with us educating. It's been fantastic.
Thank you all so much. Have a great night. Start evaluating tomorrow. Make tomorrow your first day to look at these kids a little bit differently. And take a look. You can download the sleep questionnaire. Please utilize it. Take care.
Bye-bye.